from the script still. Okay. Okay, wait, just start. You want to start?
One day, we can all stay healthy, and no one suffers from hunger. We will only realize this vision together. Together, we will come back stronger. Together, for a future with health for all, hunger for none.
My journey continues, and I know I'm not alone. Because together, we can make a difference every day.
Okay, so now it's 4 p.m. for the second day. Time to kick off the session. So is everyone ready? In this session, Dr. Oraponsi from Thailand and myself, Dr. Giang from Vietnam, will be co-chair the session. In this session, we will have 6 presentations. So may I ask if all the presenters in the room and ready for sharing your talk? Cool. So let's start with the first presentation. So enhancing mass in the left atrial appendage, common pathologies in uncommon location from Dr. NG from Hong Kong. So time is yours, Dr.
Good afternoon. I'm Pan Pan from Department of Radiology and Imaging in Queen Elizabeth Hospital in Hong Kong. My presentation topic is enhancing mass in left atrial appendage, a common pathology in uncommon location. Our case is a 50-year-old female who is asymptomatic with known history of lung nodules and hepatic hemangiomas on CT follow. Her latest CT shows an incidental finding of mass lesion in the mediastinum. These CT images showing the presence of a left side mediastinal mass at the expected location of the left atrial appendage. The coronal and axial CT images showing a bulky left atrial appendage which is heterogeneous and shows mild contrast enhancement. And the blue arrow points to the known hepatic hemangioma included in the same study. And since this is a non-gated study, the border of this lesion is rather ill-defined. So up till now, our differentials would include a left atrial appendage thrombus or underlying mass. And we have reviewed the CT performed 1 year ago, showing a static size and appearance. Our cardiology colleagues performed transesophageal echocardiograms, which shows a 5 cm hypoechoic mass. But they are uncertain about the location of the lesion, whether this is an extracardiac mass compressing of the LAA or is this a LAA mass. Therefore, CMR was performed, which confirms the presence of an intraluminal lesion in the left atrial appendage. We can see the border of this lesion is lobulated, but it is well defined. It is closely related to the left coronary artery as indicated by the blue arrow. These are the CNEs showing the relationship of the cardiac lesion with the coronary arteries. Here, this is the left coronary artery, left coronary artery. We can see the lumen of the coronary arteries are unaffected by the lesion and it is patent. For the signal characteristic, it is T1 weighted isointense, T2 weighted hyperintense as compared to the myocardium. And on fat suppressed sequence, it does not show any signal drop to suggest a fatty component. On the first pass perfusion, there is a subtle enhancement at the inferior aspect here of the lesion. And the early gadolinium, late gadolinium, and delayed post-contrast T1 weighted images showing a progressive homogeneously enhancing lesion. It is avidly enhancing on delayed images, suggesting this is a highly vascular mass. And the pearl in diagnosis of the cardiac lesion actually relies on the hepatic hemangioma, as indicated by the blue arrow. We can see that the signal characteristic and also enhancement pattern of this hepatic hemangioma actually matches the cardiac masses, actually matches the LAA mass across multiple sequences. So in summary, the CMR confirmed the lesion is within the left atrial appendage, and the presence of avid enhancement suggests the diagnosis of mass instead of thrombus. There's no invasive features, and the signal characteristic and also enhancement pattern of the hepatic hemangioma matches the cardiac mass. Therefore, the CMR diagnosis for this cardiac mass is a left atrial appendage hemangioma. Differentials will include myxoma, which is a common benign cardiac tumor. It is usually more heterogeneous enhancing. Another differential will be malignant tumor, including lymphoma or metastasis, but they usually demonstrate invasive features with heterogeneous enhancement and strong first-pass perfusion. Thrombus is not likely due to the presence of strong enhancement. For the progress, surgery was offered for definite histological diagnosis and treatment, but patient declined the surgery and preferred conservative management. Follow-up MR was arranged, but patient cannot turn up due to the COVID travel restriction. Therefore, we don't have any histological diagnosis for this case. And in the following slide, I would like to briefly talk about cardiac hemangioma and its imaging. It is a rare benign cardiac tumor. Histologically, it is identical to hemangioma in other body parts. It can be defined into capillary, cavernous, or arteriovenous type depending on the size of the vascular channel. Left atrial appendage is a rare location for cardiac hemangioma. Also, cardiac hemangioma coexisting with hepatic hemangioma is actually infrequently reported. Most of the patients are asymptomatic and the lesions are discovered incidentally. But symptoms can range from mild symptoms to severe life-threatening complications, depending on the anatomical location and size of the lesion. Echocardiogram is the imaging modality for initial diagnosis of most cardiac mass. If contrast was given, peripheral nodular enhancement with delayed filling in of the lesion can be demonstrated on contrast echocardiogram. CT and MR are useful for characterization of the lesion, but in most cases, definite diagnosis require histology. There is limited literature on CMR-based diagnosis of cardiac hemangioma. On cardiac MR, the hemangioma should be T1-weighted isointense, T2-weighted hyperintense, with a characteristic enhancement pattern of a strong first-pass perfusion, AV contrast enhancement, or delayed contrast filling. But this pattern can vary with different types of hemangioma. It can be subtle in cavernous hemangioma due to the slow flow in a relatively large vascular space, as demonstrated in our case. Some studies suggest the use of parametric mapping in investigation of cardiac mass, and hemangioma has shown to have an increased T1 value. But based on our literature search, there is no previous report on the visualization of both cardiac and hepatic hemangioma on the same imaging plane with a similar tissue characteristics as a diagnostic features of cardiac hemangioma. For symptomatic patients, management is by radical resection, but conservative management is reasonable and feasible in asymptomatic patients since it is a benign tumor and the resection can be complex. So in summary, we describe a CMR diagnosis of cardiac hemangioma based on a similar signal and enhancement pattern to a hepatic hemangioma. And although not histologically confirmed, the diagnosis was established and guided by CMR. With this case, we hope we can highlight the unique capability of CMR in diagnosis and characterization of cardiac masses. Thank you.
I think Dr. C haven't turned the microphone on, so no one can hear you.
Let me see.
Okay.
Hello. Can you hear me?
So thank you very much for the first presentation done by Dr. Ng. So I think the question will be left at the end of the session. So now it's your turn, Dr. C.
Yeah. Can you hear me?
Yes, we can hear you.
Okay, thank you. So the second presentation will be by Dr. Ingrid Maria Padit. Dr. Padit is an assistant professor at the medical faculty of Pelita, Harapan University, Indonesia. And she's going to deliver the topic of a rare case of isolated right ventricular non-compaction. Dr. Padit, please. Hi.
Good afternoon.
Okay.
Good afternoon. Thank you for this great opportunity. I am Dr. Ingrid Padit, cardiologist from Indonesia. I would like to present a rare case of isolated right ventricular non-compaction. Non-compaction of ventricular myocardium is a rare genetic condition caused by endomyocardial development arrest in embryogenesis. Left ventricle is the most common site of non-compaction cardiomyopathy, with rare involvement of the right ventricle. Cardiac MRI has an essential role in diagnosing non-compaction cardiomyopathy. We present a rare case of isolated right ventricular non-compaction confirmed by CMR. A 64-year-old female with complaint of dyspnea on exertion 1 month prior admission. She experienced progressive dyspnea or orthopnea 2 weeks prior admission. She admitted to emergency department due to syncope. She was referred to our center for further examination. No history of cardiovascular disease. Her family history was unremarkable. Her cardiovascular risk factor was dyslipidemia. On physical examination, her vital sign was normal. Auscultation, normal heart sound with pansystolic murmur at right sternal border. She had bilateral low extremity pitching edema. Her laboratory findings show elevated liver enzyme level, elevated increased LDL cholesterol level, high troponin T level, and in proBNP level. Her ECG showed normal sinus rhythm with normal QRS axis with P inversion at right precordial lead. Echocardiography findings showed right atrial and right ventricular dilatation with hyperventriculation at hypertrabeculation at RV apex. Still suspected RV apex mass. She was referred for cardiac MRI. Chamber view of sinus CMR showed prominent trabeculation and deep intertrabecular recess within the right ventricular, predominantly at apical decreased RV function, no regional dyskinesia or akinesia, no RV aneurysm, normal RV function, moderate tricuspid regurgitation. Extracardiac findings showed pericardial effusion and right pleural effusion. In comparison, I will just show our patient findings, and compared to this sample of normal right myocardial wall in adult female. We measured the non-compacted to compacted end diastolic myocardial ratio at the base RV segment. The ratio was 3.9. At the mid RV wall, the ratio was 3.6, and at the RV apical, the non-compacted to compacted end diastolic myocardial ratio was 11.2. Four-chamber view of T1 sphere sequence show no fatty infiltration on right and left ventricle, and the lattice at the right ventricle, and no myocardial infarction also at the left ventricle. Our patient was diagnosed as right heart failure due to isolated right ventricular non-compaction. She was treated with standard heart failure management and oral anticoagulant. Non-compaction of ventricular myocardium is a rare condition in adult population. The prevalence 0.014 to 0.045% on adults who referred for echo examination. Isolated left ventricular involvement is the most common presentation, 68%, and biventricular involvement is the next most common presentation, 22 to 38%. Isolated non-compaction of the right ventricular is a rare anomaly, and the diagnosis of the isolated right ventricular non-compaction is often difficult because of the absence of specific diagnostic criteria, and also because of the various degree of RV trabulation are commonly observed even in normal heart. We make diagnosis based on the criteria for diagnostic the isolated left ventricular non-compaction based on CMR findings and clinical criteria, which is a visual appearance of a non-compacted epicardial layer and a non-compacted endocardial layer, marked trabeculation and deep intertrabecular access within the non-compacted layer, non-compacted to compacted end diastolic myocardial ratio more than 2.3, the absence of other associated congenital or acquired heart disease. Dr. Nusifora present that the right ventricular non-compaction was defined as a ratio of non-compacted to compacted myocardium of equals to or more than 3 at end diastole. In our patient, all criteria were present on the right ventricle. The clinical presentation of isolated right ventricular non-compaction include heart failure, 53%, ventricular tachycardia, 41%, sudden cardiac death, 35%, cardioembolic event, 24%, and syncope, 18%. Our patient presented with right heart failure and syncope. Although ECG is found to be abnormal in about 87 to 94% of patients with isolated non-compaction cardiomyopathy, none of these changes are specific. The differential diagnosis of isolated right ventricular non-compaction are normal ventricular trabulation, intramyocardial hematome, layered mural thrombus in apex, and arrhythmogenic right ventricular cardiomyopathy. None of these pathologies are found in present in our patient. In conclusion, clinicians should have high suspicion for isolated right ventricular non-compaction in right heart failure patient without other common etiology. Cardiac MRI has critical role in diagnosing isolated right ventricular non-compaction. Thank you.
Thank you. That's a very interesting case indeed. I wonder for the criteria, as this is quite a rare disease for the isolated right ventricular non-compaction, and what do you think is the cause of this of her syncope? It's not arrhythmic related. You think it could be due to mainly the right side failure, or could there be any pulmonary embolism from your MR? Did it show any findings that suggestive of pulmonary embolism or not?
Yes. Syncope, we still looking for the arrhythmia. Although during presentation we cannot find any ECG recording that related to the syncope, but we are going to follow up about the arrhythmia for this patient. And other sign, there's no sign of lung emboli, previous lung emboli in our imaging feature. Yeah, we're still looking for the, mostly we will find for the arrhythmia.
Okay, so for the long term, look like just have to follow and treat her right heart failure and with anticoagulation. It's interesting to see because she presented quite at the age of about 60, and then her NT-proBNP is quite high for the right heart failure. So it will be worthwhile to see how to collect all these cases together and worthwhile to find out what is the natural history, as we don't have that many cases. Thank you very much for this interesting case.
Thank you, Dr. C.
Because our next presentation will be cardiac cysticercosis on magnetic resonance imaging delivered by Dr. Nguyễn Thành Vân from Việt Đức Hospital. So now time is yours, Dr. Vân.
Gentlemen, my name is Nguyễn Thành Vân, radiologist at Việt Đức Hospital in Hà Nội. Today, I would like to introduce a case report of cardiac cysticercosis on MRIs. This is 51 years old females who has a pain in a pediatric region for 1 week with an acute gastritis on gastroscopy. She had incidentally detected a myocardial mass during echocardiography. She had no previous medical history of cardiovascular disease, no chest pain or dyspnea. Blood analysis showed an increased number of eosinophils, with a count of 12%. The normal is between 0 to 6%. Transthoracic echocardiography showed a heterogeneous hyperechonic mass in the right ventricle attached to the interventricular septum, no angiogenesis, no pericardial effusion. Electrocardiogram showed a right bundle branch block. The patient were indicated the cardiac MRIs. CMR demonstrated a lesion in the interventricular septum protruding into the right ventricular chamber, while limited border with the septal muscle measuring about 3 cm. The mass were hyposignal on T1 and hyposignal on T2 stir. On CT sequence white blood, the lesion didn't cause movement disorder of the interventricular septum. On perfusion sequence, there were no enhancement or increased angiogenesis in the mass. And on less 10 minutes after injection of gadolinium, there were no enhancement in side mass, except a thin bright fibrosis capsule corresponding with cystic lesions, and no infiltration with the surrounding tissues. The patient underwent surgery to remove the mass. The intraoperative findings were a myocardial mass in the interventricular septum close to the base of the Jacobi valve, which containing colloidal fluid. Histological evaluation showed that the specimen had a necrotic degeneration with exhibited scattered parasites. The fingers show multiple tapeworm on axial plane, and surrounding tissues were infiltrated with many inflammatory cells, primary eosinophil. Immunoassay results showed that the patient was positive for cysticercosis. No other location of cysticercosis in this patient were found. Finally, the patient was diagnosed for cardiac cysticercosis. Cysticercosis is a common parasitic infection with lively approach tapeworm, Tinea solium. in typical regions such as South America, Mexico, Africa, India, China, and Southeast Asia. People infected with tapeworm by eating food containing tapeworm larvae. This disease can affect many organs. The most affected organs are the central nervous system, subcutaneous tissues, muscle, abdominal organ, and eyes. But cardiac involvement of cysticercosis is extremely rare. Apple filed 23 published cases of cardiac cysticercosis from 1962 to 2006. Roberto Spino filed 37 reports of cysticercosis with involvement of the heart in the research in 2013. Clinical symptoms of this disease depend on some factors, such as the number, location, and state of the cysticercosis, but measure of scale is symptomatic. In 2018, Neri published a case of cardiac cysticercosis that caused myocardial infarction for the first time. That was a 59-year-old man who had a typical angina 6 hours in duration with high troponin levels. Coronary angiogram showed a distal occlusion in LAD, and cardiac MRI demonstrated an intramural cystic lesion at the apex of left ventricle, extended into pericardial space. The intraoperative finding points are that the cystic lesion compressed on LAD. Histology study confirmed the myocardial cysticercosis. And our patient has no symptom of the cardiovascular disease. The cardiac mass didn't affect the coronary artery. Other imaging methods to diagnose cardiac cysticercosis consist of ultrasound and CT scan. Transthoracic echocardiogram often show an anechoic lesions. And in most cases, the CT scan finding are cystic, hypodense, well-machined, and commonly present a hypodense central nodules, which represent the parasite heads. In addition, focal calcification can be seen. Our patient wouldn't perform the CT scan. In conclusion, cardiac cysticercosis is rare and systematic, but can cause myocardial infarction due to coronary artery compression. And echocardiography is the first line for detection. Although transthoracic echocardiography and CT scan may be useful in detecting cysticercosis, cardiac MRI is the preferred imaging modality. Given the superior spatial resolution to detect cysticercosis, MRI often demonstrated a cystic lesion with the fibrosis capsule enhancement on left cardiolum. Operations is optimal treatment and final diagnosis. A thorough understanding of the characteristic of lesion imaging will help us diagnose the disease early and guide the treatment. Thank you for your attention. Thank you.
Thank you very much for sharing your interesting case. So there's a small question that in this case, if we know the cardiac cysticercosis before an operation, can we avoid an operation for the patient? Or we must do surgery?
Because of my patient has a lesion, the lesion is relatively large. It may be cause of occlusion of the right ventricle outflow tract. So I think that the surgery for this patient is necessary to remove the mass before they can cause this stenosis. And on ECG, the patient has the right brain block. It may be the previous complication of this disease. So the removal of the mass is necessary.
Okay, thank you very much. So I think maybe there will be a lot more questions from the audience. So we may leave the question for the end of the session. So time for the next speaker.
So our next speaker will be Dr. Wui Tu Tai. She'll give a talk about the asymptomatic right ventricle cavernous hemangioma, a case report. Dr. Tai first, please.
Dear Professor and colleague, today I would like to present a case study. Asymptomatic arterial cavernous hemangioma. So basically, come to Kim Hospital with for the examination with the epigastric pain for a month, and he had no history of cut, cyanosis, or syncope, and the clinical chart about gastritis. He had some general physical examination, electrocardiogram, chest X-ray, hematology, biochemistry, immunology, urine analysis, and coagulation that were normal. And the thoracic echocardiography was done by cardiology, and he showed that the systolic and diastolic functions of the left and the right ventricle was normal, and he found a tumor in the wall of the right ventricle with measure 1.3, 1.7, and 1.4 centimeter. You can see it on the video. Yes, on the fourth chamber, you can see a mass with hyper echo located on the right ventricle and has a shape change according to the rhythm of the heart contraction. Yeah, and you can see it more clearly on the in this picture for with four chamber. You can see the mass with the hyper echo with hyper echo, and it had a smooth border and clear boundary, and has like a grip, has like grip on the visual B. Yeah. The patient want to wanted to do some examination for the lung and the abdominal, so he want to had a computer tomography, and we decided to do that. We decided done it for the patient, but we missed the lesson on the CT. It's very sad because our technical they don't know about the tumor, and when did the CT, we did the arterial phase for the abdominal, and let the venous phase for the lung. So we don't see any mass on the right ventricle on the CT. It's very sad. We did a cardiac monitoring resonant imaging for the patient with a practice imaging guide of GE. You can see our protocol for the patient on the slide, and it is a picture in our department. We use the 3 Tesla of VE for the patient. In the image of MR, we can see the mass appearing with a slight hyperintensity on the stair, and intermediately signal in intensity similar to the right right ventricle myocardium on T1. Hypointense on T2, and diffuse intense at the first pass perfusion in LGE image. Yes, you can see here. And at the first time, we don't see, we didn't see any mass on the right ventricle on the 4 or 3 chamber shini. we only seen it on the two chamber. We shot Asci on the cine. Yeah, yeah. Maybe here. It's hyper intense. And after that, we had a look second for the other image, and we can see the mass in other images after see on the two chamber shot acid on cine. About the surgery and after being explained about the nature of the tumor, the patient requests surgery, and the tumor was surgically removed through the right ventricle. It is a smooth or oval noodle, and the patient had an uncomfortable post operative period and see recovery quickly. In this picture, you can see the mask with the oval nutter and have smooth flower. Have smooth powder and clear boundary and no invades other organs. Uh, about his pathology, the specimen has been analyzed for histopathology. Yeah, the result was consistent with cavernous hemangioma. In the picture, abdominal thick wall. You can see abdominal thick one here, and histologic image so delete vascular spread line with the single layer of the flat endothelial cells. The last vessels with the uneven thick one in cavernous hemangioma of the picture P, and the vessels one may be thickened secondary to fibrosis accompanied with the scattered mesoidmatic. A discussion primary cavernous hemangiomas are benign neoplasms and dividing from vascular endothelial cells and extremely rare. It was classified capillary hemangioma, angiocarcinoma, and arteriovenous hemangioma. Mostly cardiac hemangiomas are asymptomatic. In a research of Kojima et al. About cardiac hemangioma, they saw that it has about 35% on the right ventricle and about 34% on the left ventricle, 7% on the left atrial, and 23% on the right atrial. Atrial in interarterial septum and interventricular septum about 11%. Echocardiography is the first choice to detect a cardiac mass. It can show a small mass under 1 centimeter or masses arising from bands. It lacks lack of radiation, low cost, and portability. Allows for the assessment for of size, location, and mobility. A CT scanner useful in tumor staging detects metastasis in case of suspected malignancies. Exclusions of obstructive coronary artery disease or masses in proximity and helpful in surgical planning. It limited to soft tissues and temporal resolution compared with MR. In MR, the cardiac hemangioma will show morphology, dimension, location, extension, and homogeneity. Presence of infiltration in the surrounding tissues and signal characteristics, fatty infiltration, necrosis, hemorrhage, calcification, vascularity, and so forth. A heterogeneous mat intermediate to high signal on T1 or T2 with a diffusely high signal is seen. Contrast enhancement is heterogeneous and intense and prolonged. A differentiation from malignancies and thrombosis is very important for prognosis and management. In our patient, we use a table to difference. You can see we use as a green, the green color for the same symptom from other disease, and the red color for the other symptom from other symptoms with our patient. For example, our patient with diffuse inhale at the first pass perfusion and the misuma is the same, but the thrombus is no enhanced. And the papillary fibroelastoma is the same, and hemangioma and the same. And the final we saw that the hemangioma has almost the symptom is the same our patient, and we think first the hemangioma and the second papillary fibroblastoma. This update of diagnostic approach of cardiac tumor with multimodality imaging of Thayer Pelias et al. In 2020. Conclusion: cardiac cavernous hemangioma are rare and is benign lesions. It are all of them asymptomatic, and imaging method by TTM, MR, and CT, cardiac CT resection may be for definitive diagnostic and treatment in symptomatic patients. This is the reference. Thank you for your attention. This picture is about our hospital where I work cooking, and this is our college. We not only a doctor but also a shoulders. You can see me here, and thank you.
That's nice. Thank you very much for such a good case that we use the multimodality imaging, echo, CT, MR, to get to the final diagnosis of the vascular mass of the right ventricle, which is rare in this case of the cavernous hemangioma of the right ventricle. Thank you. It's a good case. Okay, so we'll move to the next presentation. Will be...
Okay, so I think the next presentation will be delivered by Dr. Nguyen from Bạch Mai Radiology Center. So the title is Acute Myocardial Infarction in Patient with Single Coronary Artery Case Report. I hope it's a very interesting case. So, Jotan, please, Dr. Nguyen.
Hello everyone, it's an honor to have opportunity to speak to you a case with single coronary artery that developed acute myocardial infarction. My presentation is divided into two parts. The first part, case presentation. A 71-year-old man presented to our hospital with complaints of spontaneous chest pain for 3 days and dyspnea for 1 day. He has hypertension typical pyridoxine value. He also have a history of smoking. Without diabetes or family history of cardiovascular disease, upon admission, he got discomfortable with a regular heart rate of 84 beats per minute. He showed clear consciousness, and other physical examination document normal findings. An electrocardiogram was performed. This ECG indicated inferior posterior wall infarction, and maybe there were lateral wall ischemia. The blood test revealed elevated level of high sensitive troponin, and it decreased over time. The echocardiogram demonstrated hypokinesis of the inferior posterior and lateral walls with decreased left ventricular insufflation fraction of 44%. According to the result of the above examination, he was diagnosed with acute myocardial infarction on day 3. He was given some drug and then referred to the catheterization lab for coronary angiography. Coronary angiography revealed a single coronary artery originates from the right coronary sinus with the absence of left main artery, left circumflex, and left anterior descending arteries. Vessel arose from the proximal part of RCA and caused to the left heart. The proximal and distal part of RCA was severely stenotic. Based on the imaging, percutaneous coronary intervention with implantation of two drug-eluting stents in the proximal and distal segment of RCA were performed, with subsequent DIMI3 flows distal after stenting. The patient recovered successfully after the intervention and was discharged in stable condition after several days. To further evaluate the origin and cause of the SCA and stent condition, coronary computed tomography angiography was performed. CCTA confirmed SCA arising from the right coronary sinus with two stents in the proximal and distal segment of RCA, which didn't rupture or re-narrow. Immediately, the origin of this main shunt, it gave up a vessel. That vessel caused anterior to the pulmonary artery to reach the anterior interventricular sulcus. A branch followed the atrioventricular groove, supplying the nominal CX territories. According to these findings, the CSCA were classified as subgroup R2A according to Lipton classification. The second part discussion. Single coronary artery is defined as a solitary coronary artery originates from a single coronary ostium in the aortic chunks and supplying the entire heart. SCA is a rare congenital anomaly, can either be isolated or coexist with other congenital abnormalities. Most of the patients are asymptomatic, therefore SCA is usually detected incidentally while imaging heart for other reasons. However, some patients can present with symptoms such as typical chest pain, syncope, or serious cardiac events such as myocardial infarction or sudden death. The single coronary artery can be diagnosed by some modalities such as conventional coronary angiography, coronary computed tomography angiography, and cardiovascular MRI. Each modalities have its advantage and disadvantage. Among these, conventional coronary angiography is the gold standard for assessment of coronary artery. In 1979, Lipton et al. Suggested a classification system in which single coronary artery is divided into 3 groups based on the site of origin and distribution of the branches. In Group 1, the solitary vessel follows the course of either a normal right or left coronary artery. Type R or L indicated that a coronary artery originates from the right sinus or left sinus, respectively. In Group 2, the single coronary artery arises from the right or left coronary sinus, and from this, a very large trunk crosses the base of the heart to arrive in the vicinity of the normal contralateral coronary artery. 6 subgroups can be distinguished based on the origins of the SCA, a right or left sinus, and the relation between the transverse trunk with the great vessels. On type A, B, and P indicated that the last trunk falls anterior to pulmonary artery, between the pulmonary artery and aorta, and posterior to the aorta, respectively. In Group 3, the single coronary artery originates from the right sinus, the circumflex, and the anterior descending branch may arise separately from common chunks. In this case, the circumflex branch usually causes posterior to the aorta, and the anterior descending branch, usually cause between the great vessel. This anomaly can be further classified as malignant or benign forms, depend on several factors, such as cause between the great vessel, proximal intramural cause between the aorta, also narrowing at the origin of the artery, sudden death, and myocardial ischemia has been reported associated with this factor. Therefore, identification of this factor is crucial for management. According to Lipton classification, our case belongs to subgroup R2A. Subgroup R2A is quite common compared to the other subgroup. As I mentioned before, almost patients are asymptomatic. The combination of SA with acute myocardial infarction is extremely rare. Some other also report the case with our subgroup. In 2015, Bowman et al. Reported the first case with an R2A subtype SA presenting with ST segment elevation, myocardial infarction, and cardiac arrest. To our knowledge, our case of percutaneous coronary intervention in acute myocardial infarction with subgroup R2A is not the first case in the literature, but it is the first case in Vietnam. There are some treatment options, including conservative and conservative management. Each option has different indication, and which option is chosen depends on each patient. In conclusion, single coronary artery is a very rare congenital abnormality and almost benign condition. And this case is very rare incident of a patient with single coronary artery subgroup R2A that develop myocardial infarction undergoing percutaneous coronary intervention through the RTA. We diagnose the SA by coronary angiography and further outline the cause of the anomalous artery in relation to the great vessel by CTA. Let me finish my presentation. Thank you for your attention. I also want to give special thanks to Dr. Viet, Dr. Lu, Dr. Lin, and Dr. Nam for their support and encouragement in preparing the case report.
Okay, thank you very much for your interesting case. So just a quick question for you as the radiologist. Do you prefer CTA or DSA in detecting single coronary artery? Because in clinical practice, we may have an arterial occlusion in the ostium of the artery. So in that case, DSA may miss the finding. So what's your opinion?
Yes. Do you want to know the SCA, DSA or CCTA is preferred in the narrowing of the origin of SCA?
Correct.
I think each modality has its advantage and disadvantage, and DSA is a gold standard for coronary assessment, but CTA is non-invasive and have high spatial and resolution to review the narrowing of the origins of SCA on. Nowadays it's become to method of choice, and I think we can use CTA to review the narrowing of the origins of coronary artery.
Yes, I do think that I also prefer CTA because we can have a broad view of the coronary arteries, and in the case of the occlusion occurs in the ostium of the artery, we may difficult to see that because actually it's quite hard to put the tip of the catheter in the right place, and we even put that we don't see the artery because it's already occluded. So CTA may give us a broad view. And so what do you think, Dr. C?
CTA will give you a bird's eye view. You can see the course of the artery, but to do the intervention, you still need the angiogram.
Yes.
So you know, in fact, mostly when patient come with acute myocardial infarction, I don't think at that point the physician think that the patient had this rare disease. So with the nowadays with the fast track of the QMI, they'll go ahead with the angiogram, and then with the findings, I have to admire the physician have to you have to have a well knowledge of all this rare congenital heart with the written classification that he has to keep that in his mind. And then after this, then you can get the open artery first, save the muscle, because muscle is time. After that, then they can proceed with the better imaging that can give you all the views where the artery course is by the CTA. So I think this is a very nice case.
Yes, thank you so much.
So time for the last.
Okay, the last case of today the topic will be double interatrial septum by Dr. Ni Hu Tran. Okay, so we would like to listen to double interatrial septum, another rare congenital heart disease found in adult, or I don't know, we'll see. Please, Dr. Tran. Hi. Dr. Tran? We cannot hear you.
Hello, my name is Nghị. I'm a doctor from Việt University Hospital in Hanoi, Vietnam. It's my pleasure to be here to share with you some interesting case. A 22-year-old man with non-specific chest pain, history and examination are normal. An ECG showing normal sinus rhythm on 2D TTE. Non-acid view, left heart and ascending aorta are normal. In short acid view, PA, IVLT, aortic valve are normal. Focus atrial septum, you can see abnormal. Apical four-chamber view, this atrial septum have a triple membrane anatomy with interatrial chamber. Focus and with color mode. Interatrial chamber communicate with left atrium. And I think it's have blood into chamber. Subtotal view, you can see clearly chamber, and it maybe have PFO on TEE, right ventricular, right atrium. There is interatrial chamber. And I think there is the continued atrial septum. With color mode is it blood through atrial septum via PFO on MCG. Left atrium, right atrium, interatrial chamber. Non-PFO, non-blood from left atrium to right atrium. double interatrial septum is described by Robertson et al. In 2006. In natural, more 22 cases have listed in the world. Is in intermediate atrial septal anomaly from interatrial chamber. Possible embryologic organs include incomplete fusion of the septal, granule and scrotum, and persistence of the left venous wall of the silent venosus. About-anatomy is distinguished between two atrial biparallel double-layer atrial septal structure. Is usually communicated with left atrial via PFO and with right atrial via accessory atrial septal filtration. Most cases of this anomaly are asymptomatic and diagnosed by TTE-focused septal view. Some cases have systemic thromboembolism because its destruction of flow between this chamber and the left atrium. Treatment by oral anticoagulation therapy, and some cases have underdevelopment of left ventricular. Conclusion: I think it's kind trouble interatrial septum and have communicated with left atrium, no thrombosis in interatrial septum, and non-hypoplastic left heart syndrome due to increasing catheter-based intervention requiring a transseptal puncture. The recognition of this anomaly is essential for performing safe and effective procedure. Thanks for listening.
Okay, thank you very much, Dr. Nick, for interesting case. And I think we finished quite early to the time, so we have to move. Now we move to the Q&A sessions. Yeah, I think this session should be called a rare case session. Do you agree to me? And is there anyone have any question or opinion sharing with us?
What do you think about the last case? Do you think there is SD? Do you think there's a double? What did he say? Double atrial septum. It's quite fast to look through that, but from what I try to put together, it looked like the patient had the ASD and also had a PFO, and there's an incomplete fusion of the septum primum and secundum. That's why you have that space in there, and that space in there, in fact, is a PFO. And initially, from the picture of the esophageal echo, it looks like there's an aneurysm. The way the intertidal septum bar deviate almost like an aneurysm. So what do you think, Dr. Kiang? Dr. Nguyen, you look at the image of the last case. This is just for discussion's sake.
I think in this case, Dr. Nguyen already have quite a lot of modality technology to prove his diagnosis, and ultrasound is not my expertise. So I think based on the image Dr. Nguyen shows, I do agree with Dr. Nguyen. And of course, I haven't seen this case before, and actually, I don't think it's my expertise in this case. Sorry, Dr. C. Yep.
Maybe the speaker can give an answer to us that you think the patient had the ASD on top of whatever you think about that double interatrial septum. Because from the TE picture you show nicely, there's a left to right shunt blood flow. There's on top of whatever the patient has, also there's an ASD. So maybe you can give us more idea of put together all your findings.
Dr.
Dr. Trang?
Yes, in Vietnamese, go Dr. Nghi. So please, Dr. Nghi, are you there?
Maybe he was mute. Maybe
Yeah. Maybe something
you
wrong
have to unmute your microphone. It's okay.
Hello, Dr.
It's okay. Just
okay,
curiosity
so
of the findings.
Yeah, maybe the problem with the internet connection or something. So,
any question from the audience? Let's see. Anyone type in any question, or let me take a quick look. No.
No. So I have a question. Actually, it's not a real question because we have some rare case in very very uncommon position as the Dr. Pan from Queen Elizabeth Hospital, and also Dr. Thủy from 108 Military Hospital in Vietnam. And yes, so for the patient with cardiac hemangioma, and they deny surgery, then we need to follow the patients up. So do you think we need to do MRI or CT again, or just do ultrasound to evaluate the size of the mass and the effect of the pathology for the adjacent tissue? Can you share your opinion and expertise with us, Dr. and Dr. Thủy, please?
Thank you for your question. Can you hear me?
Yes.
Yeah, regarding on the modality of imaging for follow-up of cardiac hemangioma or cardiac masses in general, I think MRI with contrast is definitely the priority modality of choice for follow-up of patient, because it is free of radiation, and it has a superior resolution, and also like the tumor delineation is better when compared with other modality like CT or echocardiogram, because as in my case, because the lesion is located in the left atrial appendage, which is a location that transfluorescent echocardiogram may not depict the lesion clearly. It is a location that is difficult to get with the echocardiogram unless you do the transesophageal echocardiogram. So in our case, we preferred MRI to follow up for this patient. Hope this can answer your question.
Well, thank you very much, Dr. And pardon me for my pronunciation your name.
Yeah.
Any other idea, Dr. Thủy from Military Hospital? Sometimes it's not easy to bring patients to the MR.
How about doing the echo with the contrast for the case of that right ventricle venous hemangioma? I think that will be worthwhile to look into that, because it's a vascular mass and simple to do. And on especially the right ventricle, the transthoracic, you can do it easily if you have contrast. So that's an option that that can be done to follow the patient. She's not here.
I think she's there. Maybe something wrong with the microphone or something. Dr. Thủy, I see you on the screen. I didn't hear you.
Anyway, I really enjoy all the case presentation today, that we can see different modalities can give us a lot of information and help us get to the diagnosis and for the right treatment of the patient. And all the cases are quite rare in our real life, but it's good to have a chance to look into all the image that's been shown today. Anyone have anything to add on? Or the speaker? Feel free to, we have some time.
I would like to thank you for this opportunity. I really also enjoy all the rare cases were presented today, and it's really good insight for us to learn together.
Yes, I really enjoy your case of that non-compaction of the right ventricle. Is very, so far there's no criteria, no definite criteria, because it's.
Yeah, we still using the LP non-compaction criteria for the RP.
Yeah, because it's very rare, but there's something that we have to look into that for patients come with right heart failure. And especially quite interesting to me that the patient present quite late in age. This is something that it happened with the patient since the patient was born, and then the symptom didn't show up till quite late.
Yeah, 60s, yes.
So we're looking forward to hear the progress on all the interesting case as time go on. Maybe next year, the year after, if all of you have a chance, please let us know how the patients are.
Thank you.
Thank you very much. Okay, I think it's about time. So hope everyone stay safe, and then maybe next year we'll see each other hopefully in Hong Kong.
Yes.
and thank you very much for Vietnam did a good job on this meeting. We really learned a lot from the meeting.
Thank you, everyone. And next time we'll see Dr. Pan Hung in person in Hong Kong. I hope so.
Yeah, looking forward to you guys. Thank you.
Okay,
Thank you very
bye.
much.
Take care.
Bye.
Have a good
Thank
time.
you so much. Bye.
One day, we can all stay healthy, and no one suffers from hunger. We will only realize this vision together. Together, we will come back stronger. Together, for a future with health for all, hunger for none.
My journey continues, and I know I'm not alone. Because together we can make a difference every day.